Okay, let's talk about a very kumbaya, non-controversial, we all are on the same page topic, which is opiates, or opioids. I was corrected the other day. I want to thank the member of the audience that corrected my misuse of the word opiate. The category of drugs is opioids, and if I misspeak again, I apologize. I just am not terribly accurate in this, but I do kind of slip back and forth. Technically, it's opioid, that class of drugs. It's the sort of narcotic, and narcotic is a bad word. Opioid is a much better word to use for this. But the idea of prescribing pain medicines or dealing with pain medicines and all of the issues that go with that. And we all have, it's a hot button for a lot of us. Okay, it's something where, especially having trained residents for about a bazillion years, there is a point, I think, in all of our careers where you get to this, by God, no one is prying an opioid prescription out of me. By God, I'm going to draw the line in the sand. And we all get there at some point in our careers, and some of us stay there. And honestly, I've gone the whole circle of this. And at this point in time, I have my own little sort of spiel in the thing that I do, and I know all the issues that we have to all deal with this, and we do have prescription drug abuse and addiction, etc. But honestly, there's a lot of pain that walks through our door. I can make all of it go away. And I tend to take a relatively low-ball approach. Not that it's opioids that I prescribe, but I do something to address virtually everyone's pain that comes through that door. As you get older, when you're 26 years old, the only pain you've ever been through is either you've gotten your heart broken or you've broken something, right? The reality is most young people, the residents that I train, don't have any kind of chronic pain problem, don't have any kind of real perspective on what it's like to have pain. And so their view of this is different. And as you get older, you kind of understand that pain is a really devastating problem. And if you have anyone you love who has a chronic pain condition, it's a big deal. It's actually a really big deal. It just kind of affects everything in your life. So this is a very complicated, very nuanced problem that we see a kind of skewed slice of in the ER. So let's talk a little bit about that. This chapter was written by Jim Ducharme, who is a champion of pain management. He really is. He's Canadian. He is actually kind of heartwarmingly wonderful about this. A little bit foo-foo for a little too kumbaya for other people. It's like, oh, please, seriously. But he actually wrote a very thoughtful chapter here, and it brings up some things that I think help put things in perspective for us. So the very beginning of this chapter, the idea of pain, if you look at the data, it's as low as 60 and as high as 80% of what walks through the door of an emergency department has pain attached to the chief complaint. Abdominal pain, headache, a trauma, something. Pain is a huge part of what walks through our door. But we have preconceived notions on what is enough pain, what is significant pain. And we sort of have this bar we set and expectations of behavior that we have, where we figure if you're not acting a certain way or you don't say a certain number, it's just not good enough for me to address it in any kind of way. And that's the disconnect. Most people with pain are not in our ER. They're home, or they're talking to their doctor on the phone, or they're complaining to their neighbor while over a cup of coffee. They're not in our ER. The people who are in our ER usually have an acute event that's caused it, and then you take care of that pain. Honestly, there shouldn't be hesitation. And chronic pain can be managed in a very logical, efficient way in the ED. Now, one of the things that's happened, and I think very appropriately so, and Jim addresses this in this chapter, is there's a huge focus now, appropriately so, on prescription drug use, abuse, and addiction. And we use, I think the statistic, and I think this is correct, is 80% of prescription opioids are prescribed in the United States, not North America. You Canadians are much more realistic about this. The United States prescribes the vast majority of international opioid prescriptions. That is an alarming number. Part of the problem for us is we probably fit, we not an ER, but we medicine, fed into that because there was this whole push 10 years ago on focusing on pain, addressing pain, doing a pain score, making sure it came down to a certain number before you discharge the person from the ER, really focusing on pain as another sort of vital sign. And then we got ourselves into this big conundrum. You can peel it apart and uncomplicate this by addressing pain in several different ways. And he gets into this, a couple things. So solutions to this. One is education. And we, unfortunately, have some issues in medicine. We'll talk about how to make us better. So that's one part. Community education is another, and that's happening all over the place. These news stories that are out there, patients come in understanding this concept. They do understand, in fact, sometimes too much, the idea of opioid addiction. You know, if you've broken your ankle, it is just fine to have 2 or 3 days of an opioid if it's going to make you feel better. That is not going to addict you. Okay, so there's the education in the community is part of the thing as well. And we have options that are non-opioid that we need to get really good at. Okay, not just drugs, but there are a lot of other things we can do. For instance, my husband just had rotator cuff surgery. Any of you who've ever had rotator cuff surgery know it is probably one of the most painful orthopedic procedures you can have. You spend weeks in misery while you try to get your shoulder back into some sort of function. What they did with his surgery is they gave him a scalene block as part of the first 24 hours post-op. He was eating pizza, watching TV, having a grand old time at home until that thing wore off. But it was really, so those kinds of things to think, not a scalene block per se, but do a regional block, do a dental block, use things that are part of your practice that will help address someone's pain. Do directed pain therapy. Use things that we know work for migraines. Use something like Compazine for a migraine. Use Reglan for a migraine. Use low-dose ketamine, which we'll talk about. Non-steroidals, where they're a more appropriate medicine for colic pain, which we're pretty good at this, but really focus that. And I will also tell you, one of the things we don't do well is non-pharmacologic approaches to pain. If somebody has an ankle sprain, put their ankle up on an elevated thing, put some ice on it. Have them listen to something on headphones. Have them visualize. All that stuff works. Absolutely works. Consider acupuncture in your ER. These ouchless EDs are using all kinds of practices that actually work. They work very well. So there are non-pharmacologic approaches to this that work as well. And if you have kind of an ouchless ED approach, you're going to start this from the get-go. Somebody with an acute injury is going to have this sort of RICE therapy started. They're going to elevate it, ice it, etc. So all of these things factor into being really good at managing pain, and it's not even stepping at all into the opioid box yet. There's lots of other ways to address this. So what we need to know is what to do for flare-ups of chronic pain, which is a different ballgame than an acute painful condition. Know what the medicines do as far as adverse effects, etc., and then also know your community resources. One of the things is if you have a lot of chronic pain patients that come to you, know that there are find out what your community resources are for this. I didn't realize that I've worked at our institution for almost 30 years. I didn't realize that they'd started up and have a very functional, wonderful pain management clinic, chronic pain management clinic, run by our anesthesia department. They do all kinds of wonderful things, including the TENS units and the blocks and all kinds of things, biofeedback therapy, meditation, mindfulness, all that stuff. They do, and they have and this is in my patient population, that has no resources. It's awesome. So find out what you have available to you, really important. Our training needs to be improved. We're terrible at this as far as a profession. We're terrible in training programs. So this is being focused on a lot, and I think appropriately so. The key is not to draw the line in the sand. I am not going to prescribe these medicines. I'm not going to send anybody home with these prescriptions. That's not the right answer. Okay, you're smarter than that. You're more nuanced than that. You know more than that. So that's not the right answer. All right, let's start with some of the more data in this. Get away from some of the soft stuff. How about pain scales? I personally despise pain scales. I hate them with a passion. Pain scales came around to do research. That's where pain scales came from. So that you could test drug A against drug B and say the score went from 87 to 64 with drug A and the score went from 86 to 42 with drug B, so drug B is better. That's where pain scales went, that sort of visual analog scale of 1 to 100 on that sort of 10 centimeter scale. This 1 to 10 thing is ridiculous. There's a wonderful video, you got to YouTube this. I think it's Brian Regan. Basically, it's his YouTube video of how to get, when he presents to the ER in pain, one of the things is why there isn't valet parking at every ER, or you're dragging yourself in completely sick. The other is how to get pain medicines, and it is hilarious. It's absolutely, I'm in pain. He just goes through the whole thing, the ridiculous thing. It's crazy. Pain scales are dumb. The only time pain scales work is at triage, or at the first introduction for a patient, and the data is here. It's all here. What it does is, and the reason it works is it puts it on your radar. Not because there's a number that gets spit out, but it puts pain management on your radar as a practitioner. After that first number for pain scales actually turn out to be harmful, not helpful, at getting people adequate analgesia. I think it's a lot like when you're driving around in a parking lot and you see the person walk to their car and that's the one empty spot. So you go drive up behind that person and you're going to wait. They've done studies that show what would be a sort of a 10 to 12 second time period of getting in your car, turning it on, backing out, goes up to over 30 seconds if they know you're waiting. I'm not kidding. And you know it, right? You've had it happen. It's the same thing with the pain scale. It's like, oh really? Your pain's an 8? I'm going to go give somebody some ibuprofen and take my coffee break. And then I might come back and maybe address that pain scale. Show me you're having that much pain. We're terrible at this. And it turns out nurses are worse than the physicians are overall. But pain scales turn out to be a big problem. And the more somebody says it's a 12 out of 10, the more unlikely you are to give them a medicine, right? It's just reverse psychology. It always works. It always does. My personal approach to pain is I introduce myself to all the patients in the ER. I say, hi, I'm Dr. Birnbaumer. What's bothering you today? How can I help you? Are you in any pain? Would you like something for that pain? And we start with that on the table. They don't have to moan and groan and get your attention and shriek and cry. They get to say, actually, yeah, I'm hurting. And then if they say that, talk to them about what you want to do to manage their pain, whatever it is, visualize or what, I don't care what you do. Give them some ibuprofen, whatever, put some ice on it, I don't care. Give them an opioid. But then go back and say, is your pain better or worse or the same? Not what is it on a scale of 1 to 10? How incredibly stupid is that? Seriously. Are you feeling better? And are you feeling enough better that we're good to go? Or would you like a little something more? It is, and when people know they don't have to play any game with you, all of a sudden it's what amazes me is how often someone says, yeah, it hurts a lot, but I'm good. It's like, actually, no, you're here, I can fix that. It's okay. And I get it. If you don't want medicines, that's fine. But I'm going to swing back by in a couple of minutes and see if you've rethought this, because anytime, let us know, we can fix it. It de-escalates that whole garbage of all of this. They don't have to moan and groan. They don't have to make a big scene. They don't have to figure out a number to kind of get your attention on their pain. They can just say, I'm better, I'm worse, I'm not. It's wonderful. It actually works very well. And this pain scale thing, although it's part of all of our EHRs, the nurses really focus on it. Just try to step aside from that because it turns out to be counterproductive overall. Now, are there certain patients in our setting who are more likely to be undertreated for pain? And the answer to that is absolutely yes. And the groups are heartbreaking. And the data is repeated over and over and over again. The people who get undertreated for pain are people who, for some reason, either can't communicate well with you how they're feeling, or groups that we can't relate to very well as far as how much pain they may have. So it's the very young. And I'll tell you the data, there's an article in here that just breaks your heart. The very young, the very old, the crazy, okay, where they can't communicate with you, or people of color. So it turns out that people of, and it's just color different from you, and actually it isn't even necessarily color different from you. The study that Jerry talked about from UCLA, there were a lot of Hispanic patients who were undertreated for pain, and a lot of the physicians treating them and nurses treating them were Hispanic. So it isn't even necessarily color different from you. Part of it is this communication thing, where we expect someone in a lot of pain to not watch television, to not eat a meal, to not sit there calmly. We expect them to be, wailing away and moaning and groaning. So part of it is that they don't behave the way we expect them to, or they're just people we can't relate to well, just because we can't. That to me is something that you pay extra attention to. The data on the elderly, long bone fractures in the elderly. You break your humerus, you break your femur. Okay, those are the studies they look at primarily in the elderly. Less than half get any pain medicine, and anywhere between 10 and 20% get an opioid. The rest get some Tylenol. Are you flipping kidding me? I break my femur, I'm in pain, you either give me morphine or you give me a femoral nerve block, period. Just do it, okay, just do it. It's miserable. The data on children is alarming. The data on children is just heartbreaking. There's one study in here where only 10% of kids with long bone fractures got any sort of pain medicine at all, and most of that was Tylenol, that's it. So all they got was acetaminophen. So just the key is to focus on it, pay attention to it. You don't necessarily have to know them. You just have to make sure you pay attention to it and know that there are options out there for treating their pain. So it's that communication issue that's the biggest problem. Now, if we educate ourselves, can we improve our management? Yes. So it turns out that education programs do work. So things like in California, to keep our licenses, we had to go through this pain, 10 or 12 hours of pain CME about 10 years ago, 8 years ago, that we had to do. And it did improve people's management. What was interesting, though, is not the physicians so much. When you teach nurses, nurses are much better at changing their behavior than we are. And since nurses are our interface for pain medicines, that's actually kind of nice. The other thing that's changed this is we are no longer allowed to order PRN drug dosing. Thank God. Okay, for pain medicine, thank goodness it's not PRN. And the best way to approach pain medicine as far as dosing is concerned is to offer it. So the doctor has written an order here, or the practitioner has written an order here for X amount of medicine. Would you like that? No? Okay, well, I'll come back and offer it again. Offer it. They're allowed to decline, that's fine, but don't make them beg for it. That's just key. So education programs absolutely work. If you look at our prescription, the next section looks at our adequacy when we finally do step into the opioid box. Okay, fine. You have wailed enough to get my attention. You have self-flagellated and just you're prostrate everywhere, you're miserable. I will give you narcotics, or opioids. The dosing range of what we give varies 27-fold if you look at the literature. And I'll tell you the standard dose, and I guarantee a lot of us do this. I don't need more at all, but I used to. Morphine, I'll just use morphine as an example, comes in fours and fives. Basically, the sort of unit dosing is 4 milligrams, 5 milligrams, or 10 milligrams. Those are the unit dosing in its IV form, in its parenteral form. We tend to err on the low side, and I cannot tell you how many times I've seen 4 milligrams of morphine prescribed for a 220-pound guy who's a multi-trauma victim. That is ridiculous. The dosing of morphine, the adequate dosing of morphine is 0.1 to 0.2 per kilo. So if you take a normal adult, 10 milligrams of morphine in a normal adult is a fine dose. The only time you should hesitate to not give 10 milligrams of morphine is the elderly, because they're a little more fragile, so go a little lower in that group, or somebody who already has something on board that makes you worry about their mental status. For instance, a heavily intoxicated person. But then what you're going to do is titrate dosing. So the two errors we make in opioid dosing is inadequate dosing for the first dose, and then not titrating to effect. So one of the key to this is that swinging back by in 20 minutes or so and saying, how's your pain? Better, worse, a little better, a little worse, just the same. Would you like something more if they're still in pain? And then titrate the dose. The second dose is usually half the first, but you're going to titrate that until they're comfortable. They're not snowed, they're not pinpoint pupils and not breathing. They're just comfortable. That's your goal. And the thing about pain that's interesting is that if they cycle into they're really miserable, they've gotten into this like socked in pain cycle. What you have to do is break that cycle. Once you've gotten the pain under control, it's really easy to keep it there. I'm going to talk about PCA in a minute, but PCA is the classic example of how that works. So you've got to break, don't let them sit there with inadequate doses where they're still really uncomfortable. Break it, and then keep them there with titrated dosing. Phenomenally effective, remarkably effective, really, really useful. This is the article about long bone fractures in this section that's just appalling. So just know that that's the best approach to narcotics, however you decide to use them, the opioids, that's the best way to sort of do it. And what works the best, honestly, are protocols, because if you take our judgment and you throw our judgment in there, and we drop down menu of your drugs, and that 4 milligrams of morphine is that first thing that pops up there, our gut reaction is to click that. I'll give some pain medicine, but I don't want to give too much. Either take that out of your drug choices or get some sort of protocol involved, where it's 0.1 to 0.2 per kilo is the default dose, rather than you choose a dose. It's actually a default dose. It tends to work better. These drugs are highly safely, they're very effective and pretty much very safe used appropriately. Now PCA is in here. Anybody use PCA where you work? Oh, you do. Actually, hands high. I'm kind of curious. Got one here. In the ER, you use PCA?
Rarely. It depends on where we are. I'm also a hospitalist too.
Oh, fantastic. So you use them as a hospitalist. Do you use them in the ER as well?
Yeah, I'll start PCA I'm a small hospital, so if I'm the ED attending that night, I'll start PCA from the hospital.
So if you're the ED attending, you can start it knowing that you're basically admitting to yourself into your service in the hospital service. You use it as well? But you said you do. In the ER?
Yes.
How did you get that protocol set up in the ER to get the nurses to buy off and the whole, nursing administration and all of that? Do you know?
Pharmacy committees.
Pharmacy committee, God bless them. So you must have a pain champion somewhere at your hospital. What turns out to work, if you really want to address this at your institution, you need what's called a pain champion. You need usually a doc and a nurse, and it helps to have a pharmacist, although the pharmacist is just the sort of reminder person. You still have to be the delivery person. You still have to have the order. But if you get a pain champion involved, they can push something like PCA. I personally had PCA after both of my knee surgeries. Knee surgery is just not fun. When you come out of an ACL repair, your knee is going from like the minute you come out of anesthesia. It's miserable. And they had a PCA pump. And PCA is the thing that is absolutely true about PCA is it does exactly what we were just talking about. You never get to that locked in pain point ever. You get to keep your pain to your comfort level, and the placebo part of pain control, because you're in control, is really important. My pain's not so bad right now, I can handle it, or oh, it's absolutely miserable, and you can push the button 1,000 times and there's a lockout. So over a certain amount of time, there's only a certain amount of drug you can get, although your brain thinks you're still getting something. So the placebo part of that really works. And every single study that looks at PCA says less drug is used over the same amount of time. Patients are much more comfortable with this, and it's safe. Why this hasn't gotten trickled down into it's not that hard to set it up, honestly. It's just not. The machine is set. If the drug is put in there, it's all programmed. You push the button, patient has a little thing, you're done. It's easy. I think this is kindness sort of mechanized. It's fantastic. So just know PCA is out there. We pushed for this, and the pushback we got was from our nursing staff. They didn't want to set up one more thing. Our nursing staff right now is very passive aggressive because they've been asked to do this EMR stuff, and they were also asked to do a bunch of other non-nursing duties as part of this. And so our nursing staff right now is really passive aggressive, and nothing's happening outside of what they're absolutely mandated to do. If you have a cooperative staff though and a champion for this, it's great. Now, another thing you can do that most of us have access to very easily in your ER is ketamine. Ketamine is interesting. Ketamine it kind of surged back about 25 years ago for sedation, particularly in kids, right? You need to do a lac repair or something. It was great for kids. Ketamine is now drifting into all kinds of things that might be wonderful. One of my current love it things about ketamine is agitated psychotic patients. So we see a lot where I work, that we are the referral center for all the psych crazies in our area, and we see a lot of drug use. And so that person that's being held down in the back of an ambulance by 6 people who is whacked to the gills, that is a danger to everybody, it turns out you can use IM ketamine, 4 to 5 milligrams. You basically just slam it in a big muscle somewhere, slam it in there, and then back off. And within about 60 seconds, that agitated, combative, sweaty, wacko person is out, and you can start an IV, safely restrain them, get some other meds on board to keep them sedated when the ketamine wears off. It's very well studied in the pre-hospital setting. So just so you know, ketamine is now out of just sedation for procedures. It's helpful in agitated psychosis, and it's probably helpful in pain management. It turns out that sub-dissociative doses of ketamine, so not that big whopping dose. This is 0.1 to 0.3 per kilo, sub-dissociative doses of ketamine. Turns out that, particularly used with an opioid, is opioid sparing. You need less of the opioid and very effective. That's in acute pain. It is not effective as a sole agent in acute pain. So know that. So I have a trimalleolar fracture of my ankle. You can give me some morphine and some ketamine, and you'll need less morphine. Ketamine has some analgesic effect. It has a little bit of sub-dissociation. It helps as far as the pain control is concerned. It does not work as a sole agent in acute severe pain. So you need to have it with an opioid. But it does work as a sole agent in some flares of chronic pain syndromes. So back pain, it's been studied, not super well. It's more sort of, we tried it, we liked it kind of studies in the back pain. Migraine, sort of exacerbations, it's been used. The downside to using ketamine as a sole agent is that there is some dysphoria. The dysphoria rate is about 10 to 30% of patients will have some dysphoria with that sub-dissociative dose. Your options there are either to talk them out of it, Okay, so, and I'll tell you, the thing about ketamine I've discovered is a lot of ketamine's psychological aspects, that sort of emergence thing, is related to how you do this and in what setting. If the person is getting ketamine next to a shrieking, crazy person, they will not do well with ketamine. But if you put them somewhere quiet, where it's actually, and a lot of us have ERs now where you can make, the room is their own, okay, it's nice and quiet. Keep it quiet, lights down a little bit, talking them through it, both for subdissociative doses and dissociative, talk them in comfortably, they come out just fine. So ketamine turns out to have a role even in pain management, chronic pain management as a sole agent, acute pain management with an opioid, and I'll tell you the one group this doesn't seem to work in is sickle cell. And I don't know why, but in sickle cell patients, the ketamine doesn't seem to do much at all except cause the side effects. So it's the one group where I kind of hesitate to use it, but overall ketamine is great. This is at the IV dose is 0.1 to 0.3. There are some studies looking at it intranasally. Little new atomizer thing that we're sticking up kids' noses and giving fentanyl and all kinds of stuff. It may be deliverable that way as well. I'm not quite ready to switch my practice to that, but just know ketamine is out there as an option for you. Now, the last little bit that Jim gets into in this chapter is, I think, really interesting, but I find difficult in a practical standpoint. One of the things he mentions is we do get in this, you're not getting any drugs out of me, bub, kind of approach. And we think we can tell who the drug seekers are. Yeah, I love it. The term that's always thrown around wrong is pain seeker. This person's a pain seeker. Actually, no, there are certainly pain seekers out there that like that sort of thing. These are drug seekers. The reality is, when they've done studies looking at, where they do is screen patients for risk of addiction, and there's some really well-validated, actually, scoring systems to screen people for, are you at risk of becoming addicted to a drug if I give this to you? What they find is when they do that screening for people, and they find who the high-risk people are, and then they actually look at who those individuals are, about half the time, we have no idea that that person is at risk. It's the three-piece suited guy with the 1 martini lunches. It's the mom at home with her 3 kids. It's not the whining chronic back pain person that you're so sick of seeing. So it turns out we are terrible at figuring out who's seeking drugs and who's at risk for addiction. We're just not good at that. And it makes sense, okay? People are complicated. It makes sense that it's not so simple. There is a pain score, or not a pain score, a risk score. It's called the Opioid Risk Tool. He makes a reference to it. It's in the Canadian Medical Journal. It's actually, I brought the article, which is a fantastic article. If you want an amazing article for chronic management of pain, what to do about it, most of this is outpatient stuff, but there's some great applicable stuff for us. It's a 2010 paper that came out in the Canadian Medical Addiction Journal, I believe. But it basically has a scoring tool here that I think is going to be really hard to try to use in the ER. I went to look it up because the data on how good it is fantastic as far as picking out who's at risk and which ones you should kind of step back and maybe not give an opioid prescription to. The problem is the kinds of questions you need to ask. So say you have somebody who's there with a fractured ankle, and you're thinking about giving them a good slug of opioids in the ER and some to go home with. They recommend in these people asking the following kinds of questions. Things like, gender and age, that's easy. History of alcohol use and drug use, I'm okay asking that. I ask that of a lot of people anyway. I'm kind of cool with that. But history of pre-adolescent sexual abuse. History of a family history of drug or alcohol use. All of these things make you more prone to an addictive personality problem. And I'm not sure although this score works beautifully, I'm not sure it's something that I could comfortably integrate into the kind of patient interaction I would have when an opioid might be on the table. You can decide if this is helpful to you. It's just one more scoring system that's kind of a pain in the neck, to be honest. But it's very helpful, especially in chronic pain management. Yes, please.
Yeah, a problem I would have with that sort of a score is that when I ask patients whether they're taking opioids, and then compare it to the prescription monitoring program, there's often a dissociation effect usually. So that I find that people who I've seen, and I find them 50 times on a list for taking opioids in the last year, will tell me, no, I may have taken opioid, I may have had an opioid prescription twice in the last year. Mm-hmm. So I don't think that you can really rely on the score in that situation.
Probably not. So what he's mentioning is something that I think now is mandated nationally. I know it's mandated in certain states, and I think it is now a nationally mandated thing that there is now a prescription drug database that, and in California it's called Cures, and we basically, before we write a prescription for an opioid, we are now mandated to go look up and see if this person has had a prescription in the database. What is interesting about that is patients now know that, especially that kind of patient who has, although I'll tell you what's happening now for the patients I see, is I say, I understand you're having a lot of pain, I understand that completely. I'm gonna go check the database because I'm required to do so, and just we'll see about sort of what prescription you get, because it's in this database, whether you've had a prescription. And they will say, hang on a sec. Just wait a sec. Maybe ibuprofen's okay today. Or they'll get up, take their gown off, and leave when they know I'm going to check the database. They're out. That happens more often than not, actually. They just get out and leave because they know now that we have to check. So for us, it's been actually wonderfully helpful. And I'll tell you, it goes both ways. It's not just the person who says, I haven't had a prescription for 6 months, and they've had one every month for a while. We had this happen twice just last week, where the residents came out of the room and said, this person just wants a prescription. Low back pain, whining and moaning and groaning, went to Cures, no opiates for over a year for both of those patients. So they didn't get, they would have gotten nothing. I mean, and the residents were like, about it. These people were totally legit. So it works both ways this way. It's wonderful. It's absolutely wonderful. So what Jim says at the end of this, yeah, go ahead. Somebody, yeah.
So interestingly, Jim was giving this talk at the Canadian Association of Nurse Physicians. At the same time, the provincial pharmacologist was saying that we're killing people.
Yes. Yes, of course.
Great,
right, and so the reality is we are killing people, but we aren't killing people in the ER. The people who are killing people are these drug churning docs that when you go on those databases, it is amazing. You'll see the same doc prescribing 100 pills every month or 200 pills every month for the same person.
So why even prescribe for someone who's just coming in for a refill?
So we don't. So what we have now in LA County is we no longer refill narcotic prescriptions at all. Period. And actually what's interesting is the analogy so Jim makes a really, really good analogy to help you get your head around chronic pain versus acute pain. Acute pain, I fractured my ankle. Those people get a couple of days of an opioid, they get sort of good local therapy thing. That acute pain is totally different. And if you have a chronic pain patient who fractured their ankle, please treat them for their fractured ankle, for heaven's sakes. But the chronic pain, what the analogy he makes that I love is, would you futz with somebody's hypertension meds or diabetic meds because their sugar or their blood pressure is a little off today? You wouldn't. Chronic pain patients need to be managed chronically by someone who knows what they're doing, and today's little flare isn't something that we should be futzing with a chronic management plan. And I like that, and that is something people, they don't like it, but they understand it. Your pain, your problem is chronic, just like hypertension, just like diabetes. And my futzing with what is your management by your physician is inappropriate. Inappropriate. Now, if they fracture their ankle again, that's different. That's not my chronic back pain is worse today. That is, I fractured my ankle and I have chronic back pain. So and people, they don't like it, but they understand that. So we're not allowed to refill opioid prescriptions in the ER. Flat out, LA County, we're not allowed to. But we have to be careful not to ignore acute problems and translate that inappropriately. So I think that, so we have to consult the database. We don't refill prescriptions at all, and they are basically, they have to go back to their primary care physician or their whoever. Yes, it does. Yeah, as long as they don't have hard neurologic findings. So, and that's hard neurologic findings. That isn't necessarily the sensory stuff. We're talking about true measurable neurologic findings. And that gets a little harder. And that ends up kind of a little judgment call. Yeah?
Do you treat those people in your ER for pain as you're working them up and then tell them, I think this is a flare of your chronic pain, I'm not refilling anything?
It depends.
Do you not treat them in the ER?
It depends. So so if it's a chronic pain problem, and back pain is the most common of these, fibromyalgia is another one, where it's a chronic pain problem, what we do is we address this from the beginning. So I go get a little history, make sure there's nothing acute going on, and the talk happens at the beginning. This is a chronic pain problem. I'm going to go check your Cures database here, just sort of see where we are as our playing field, so that we all kind of know where we stand here, and then I'll figure out the best way to approach your flare of your chronic painful problem here. So rather than, and what I'll tell you is EHRs make this, because your tendency in EHRs click the drug because you're busy. So you have to kind of step away from that and go right to the bedside and address it up front, like a triage, basically. It's like a pain triage. Yeah?
In Illinois, it's a voluntary program. The pharmacies aren't always documenting the prescription as they occur. And then the patients will often say, I tripped. or my dog knocked me down, those kinds of,
Uh-huh.
you can sense that this is.
So he's saying that the pharmacies aren't necessarily keeping up to speed. I can't change that, whatever, I can't change that. All I can do is go to the database. Right, and then the chronic pain patient who says, I had a something, I tripped, I sprained my ankle. There's only so much I'm gonna fight on this, honestly. It's like, well, okay, fine. I'm gonna err on the side of being a kind person, and I'm not gonna play the are you manipulating me game. I'm just not. If they say I had an acute event, they had an acute event. Who am I to judge that? It gets to the point where I'm now real comfortable with the slots I put people in, and if there's any gray, I err on the side of making them feel better, because I can do that. I feel like a better person at the end of the day, and I'm not getting taken by everybody who comes to the ER, so.